Good afternoon, dear chairpersons. Thank you for the introduction. Good afternoon, dear professors and colleagues. I'd like to thank my professor, Dr. Rasha Kamal, for inviting me for this annual successful conference. Today, I'm going to present a film reading session. I will present during the next coming 30 minutes multimodality breast cases, presenting typical findings and atypical findings, and there will be some dilemmatic cases which will be interesting to most of us. I will present different breast pathologies from benign and malignant lesions, inflammatory, proliferative, and vascular lesions. All these lesions will be pathologically correlated. So let's begin our short journey here in the breast cases. Our first case is a 64-year-old lady with a palpable right breast lump. The mammogram showed a well-defined lobulated lesion of intermediate density. On a close observation of this lesion, we can find that the posterior margin shows fine irregularity, which was confirmed by this complementary ultrasound, showed the angular and irregularity in the ultrasound. The lesion was actually of not parallel orientation, and it was biopsied and proved to be a fibroadenoma with foci of DCIS. There was another lady, 35-year-old, performed her ultrasound only because it thought she was a young patient. We found here a well-defined lobulated lesion and another lesion which was of that of the clinical concern, the lesion she came complaining of, showed a hypoechoic echogenicity. Also, it shows not parallel or not parallel oriented, and internal calcific foci within and internal cystic spaces. And actually, there was no appreciable vascularity on the color Doppler. All these findings being well defined, the tiny cystic spaces and few calcific foci, and on performing her tissue biopsy, went with a fibroadenoma with foci of DCIS. So it's very important to discuss this topic. We found a research article done in 2019 explaining the uncommon pairing of the ductal carcinoma in situ within the fibroadenoma. The paper suggests some findings that when I can see in a typical fibroadenoma or in a fibroadenoma, I should recommend tissue biopsy to exclude any underlying malignancy. This includes if the lesion increased in size, showed calcification in an old age patient, if the lesion showed fine irregular margins as our cases, or with internal cystic changes or high vascularity or contrast enhancement in any contrast study. The following case is a 55-year-old lady coming for screening. She performed the mammogram, which showed this regional, pleomorphic, heterogeneous, amorphous microcalcific foci. We can see that extends toward the nipple with a linear or ductal distribution. Another lady also came for screening, showed this clusters of microcalcification, showed the same features of pleomorphic, amorphous, and both were impressive of malignant microcalcification. This is another lady, also came for screening. Actually, we find this very faint, dense shadows. This was an annoying finding because actually this patient performed her last year annual mammogram and it was completely free. So this was a questionable finding. We began to ask the patient, search on her skin if there is any abnormal clothing, abnormal thing on her skin. There's abnormal contrast in the plate. And actually, after investigations, we found that the patient performed a tattoo, and this was a skin tattoo. So very important to put it as a differential diagnosis, the skin lesions, because it may misdiagnose as a pathological diagnosis. And actually, this is not a picture of a malignant microcalcification, it's a skin mark or skin tattoo. This is another lady coming with bleeding per nipple. She performed a mammogram which showed the right retroareal fine tubular densities. In the ultrasound, there was a dilated ducts with internal echogenic soft tissue shadows showing the classic pedicle vascularity on the color Doppler, and on excisional biopsy, this was proved to be an intraductal papilloma. This is a classic picture of the intraductal papilloma, actually. This is another lady, 16-year-old, coming for her ultrasound with a left breast lump. Ultrasound examination on the lump showed this large hypoechoic lesion of heterogeneous echogenicity. It actually takes the ductal, more or less ductal distribution. Some areas of these lesions are more echogenic, and it was highly vascular on the color Doppler. Being in hypoechoic, facing this distribution and vascular on the color Doppler, an intraductal lesion actually was suspected, and we considered something like an intraductal papillomatosis. Actually, it was put as a PIRAS 4, and we asked for a tissue biopsy, which came with being a fibroepithelial tumor, cellular fibroadenoma versus phylloids. Actually, it was a pathology we weren't acquainted with because of this abnormal distribution. So here we need to distinguish between the fibroadenoma and the phylloid tumor. There's some criteria we can help us in differentiating between both. Fibroadenoma occurs in younger patients, it's slowly progressive than the phylloids, and the phylloids is more common. Recurrence is more common in the phylloids. Phylloids is largest in size, reaching from 3 to 4, beginning from 3 to 4 centimeter. It's more irregular and microlobulated margin. Calcifications is more common in fibroadenoma than the phylloid tumor, and associated secondary findings are more common in the phylloids, mainly in the malignant form like the skin retraction or the associated edema, for example. Regarding the vascularity, the phylloids is more vascular than the fibroadenoma, showing more central or high central vascularity on the color Doppler. Regarding the radiological findings, both may present in the mammogram by a rounded density with smooth borders. In the ultrasound, the fibroadenoma more well-defined margin, and the phylloids is microlobulated with or ill-defined. The fibroadenoma shows hypoechoic homogeneous internal echo pattern, while the phylloids may show a complex echo pattern with internal cystic cliffs or spaces between inside. In an MRI, the fibroadenoma shows hypointense internal septations with the fibrous septi, and the phylloids show the internal cystic areas or the cliffs within. Okay, the following case is a 55-year-old lady with a left breast lump. Her mammogram showed this lesion of intermediate density of lobulated outline or margin, and the ultrasound showed this hypoechoic lobulated lesion with high central vascularity on the Doppler application. Tissue biopsy was confirmed for this suspicious lesion, and it came to be an intraductal papilloma with focal DCIS. Another lady, 54-year-old, came for screening showed this small, intermediate, dense, well-defined lesion. Ultrasound confirmed the benign findings we suggested in the mammogram, and it was put as a PIRA-3 for 6-month follow-up. But unfortunately, the patient lost her follow-up and came after 1 year, performed her annual mammogram, which showed increase in size of this lesion. And ultrasound also showed the increase in the size with the irregular margin or the angular margin. And so, of course, we did a biopsy, which came to be an invasive duct carcinoma. Actually, it was a ductal carcinoma with invasive component. So here we can see that we have 2 different masses. Both are well defined, but one just showing foci DCIS and the other shows an invasive component. We will present more about the ductal carcinoma in situ by an interesting case presented by my colleague, Dr. Iman Ewais, for the following the next 5 minutes, inshallah.
Thank you, my dear colleague, Dr. Iman, and my professors. I'm presenting for you a 51 years old female patient. She's a very interesting case. She presented for a diagnostic mammography for a palpable lump in her left breast. She said that it has been there for 2 years. And she had a history of bilateral breast augmentation 15 years ago, and she reported no family or personal history of breast cancer. We performed mammography instantly for her. These are the digital mammography images of her breasts, showing a focal asymmetry involving the outer quadrant of the left breast. And as you can see, this asymmetry is displacing the implants posteriorly and medially in the left breast. As we look closely at this asymmetry, we can see very characteristic nodular densities along this asymmetry matrix, very clearly seen. These peripheral nodular densities, no calcification or distortion were identified. When we performed complementary ultrasound for this patient, we can see here a very condensed parenchyma of some cysts and dilated ducts, and some of the cysts showing clustered tendency, and some are clear. And some of them, actually, we identified 2 cysts showing 2 small, tiny, solid papillary nodule, like the one we measured here, and also the one we measured here. And as you can see, when we applied Doppler ultrasound, there was no vascularity noted related to this asymmetric tissue, neither the ducts or the cyst or peripherally or even for within these tiny solid nodules identified within the cyst. Her ipsilateral axilla showed no pathological lymph nodes. It was a very questionable case for us. As you can see, this is a presentation. This presentation could represent anything. It's an asymmetry. There's dilated ducts, there is cluster cysts, there is some intraductal papillary solid lesions. So it could be anything from a typical form of fibrocystic changes, apocrine metaplasia, papillomatosis with cystic changes, or even a form of malignancy that we couldn't guess. So we give it a PIRA 4B, and we recommended an evaluation by MRI and also a biopsy. The patient performed MRI in an outside clinic, and these are her images. This is post-contrast map images showing a clearly identified non-mass enhancement seen confined to the same area of asymmetry we identified in her mammography. There's no other abnormality seen in the breast, and if we look at these post-contrast T1 subtraction images, we can see more of the pattern of enhancement of heterogeneous non-mass and clumped enhancement involving the whole area of asymmetry. And we also identified some non-enhancing areas, and we can see them more clear here in this non-subtraction post-contrast images. These ones, and of course they are corresponding to the small cyst and the ducts we have seen in the ultrasound, and they are clearly seen in the T2 images. So we came also to a conclusion of BIRAS for this non-mass enhancement. And of course, this is a very questionable lesion. And in these cases, the pathology will give us a definite answer, and it gave us an extensive intraductal micropapillary carcinoma with no invasion reported. Her surgeon performed a surgical biopsy for a more accurate diagnosis, and it was very accurate. And this is a very rare case, actually. And to know more about micropapillary intraductal carcinoma, it's the least common subtype of DCIS, and it has given its name in 1997 when Scott et al. Suggested that it should be a special type of intraductal carcinoma to be differentiated other than other types of ductal carcinoma in situ. And also it tends to involve the ducts extensively when presented in pure form, regardless the grade. Also, it has its own high risk, and it has an independent high risk factor. For example, even in low grade patients of micropapillary ductal carcinoma, they should receive radiotherapy and also sentinel node assessment, because micrometastasis to the lymph nodes usually found and reported. So, and also in our case, she performed a sentinel node biopsy and it was negative. But of course, this is the right guideline. Also, the micropapillary carcinoma shows a more distinct morphological architecture, and it has been reported to show a club-like micropapillary and here we can recall our ultrasound finding of this tiny intracystic papillary lesion. And also, it is known of lack of fibrovascular cores. Also, this is found in our case where no Doppler ultrasound signal was reported, whether for the solid intracystic lesions or even the whole lesion. Also, the non-comedo subtypes of ductal carcinoma in situ, like the micropapillary, it tends to grow without necrosis or calcifications. Of course, sometimes they calcify and show a segmental or a ductal distribution of calcification, but in our case, it showed no calcification. So usually when they are not calcifying, they present as asymmetries or masses, or an even more occult mammography presentation. I'm just sharing with you here another image for another case, which also was proven pathology as micropapillary carcinoma. But with calcification, as you can see here, they are like twin images, but this one was of a higher grade. And when we magnify the image, you can see here clearly these suspicious fine polymorphic calcification associated also with nodular densities in this asymmetry. In the ultrasound findings in DCIS without calcification, it's really a non-specific finding. As we saw, we can it resembles papillomas or ductictasia or fibrocystic changes, or even came out associated with atypical ductal hyperplasia. I hope this case helped you to solve some of similar puzzled cases. And thank you for this opportunity.
Thank you, Iman, for this interesting case. I just want to ensure from this case that pathology, in most of the times, or in some cases, it is the only definitive tool for diagnosis, apart of course from the radiological findings. Thank you very much. Okay, in continuity for the cases, and as Iman presented a case with the post-silicone implantation, I also have a case here with the post-silicone implantation coming with the right breast lump. but this time she has a calcification, suspicious microcalcification or microcalcific clusters along this suspicious lesion. By the complementary ultrasound, we found this large hypoechoic heterogeneously echogenic lesion with the high vascularity on the color Doppler. Another satellites or another lesions were seen also in another areas of the breast overlying the implant. The ipsilateral axillary lymph node actually was pathological with eccentric hilum. She performed an MRI which showed and confirmed the lesion seen, showed heterogeneous enhancement of such lesion and of the smaller lesions also seen. The map here confirmed also the homogeneous enhancement of the lesion. Together, putting the findings of the mammogram, the ultrasound, and the MRI, and of course, a tissue biopsy was taken from this actually suspicious lesion, and it came to be a lymphoma. So this was a case of post-silicone implant lymphoma, and this one was one of the late complications of the silicone implantation. So it's actually is an interesting case because this is not common to be seen in our everyday practice. So actually it was a nice case. The rest of the cases I will actually present it in the form of duos or 2x2 cases because I want to deliver a certain message after presenting each two cases because it will help us in distinguishing between different pathological diagnoses. For example, this lady coming with a right indurated tender breast, her mammogram showed this global asymmetry with a pathological enlarged lymph node. She performed ultrasound, which showed this ill-defined hypoechoic area, which was highly vascular on the color Doppler, and with overlying skin thickening and underlying interstitial edema, with the ipsilateral lymph node was actually pathological lymph node. She performed an MRI which showed a low T1 and intermediate bright T2 signal of the area with the pathological lymph node. On the dynamic study or the contrast study, it shows homogeneous enhancement, and together the findings of the ultrasound and the MRI with the tissue biopsy confirmed being a granulomatous mastitis. This is another lesion, a lactating lady, 32-year-old, coming also the indurated tender breast by ultrasound. We found the skin thickening with the underlying also hypoechoic area, which was highly vascular color Doppler with a pathological axillary lymph node, actually very similar findings. And on an MRI, she showed the area of being low T1 and low T2 with overlying interstitial edema and the pathological lymph node. On the dynamic study and the contrast and the maximum relative enhancement image shows a homogeneous enhancement of such area. So together the ultrasound and the MRI findings and along with the biopsy confirmed being an invasive ductal carcinoma. So here we are confronted by two pathological diagnoses, one a benign and one a malignant. It's very important to distinguish between both because there is completely different in prognosis and treatment. The benign lesion like granulomatous mastitis will undergo corticosteroid therapy, while the malignancy will undergo her plan either with surgical, chemotherapy, radiotherapy. So both are two different entities, it should be differentiated. Simply if we have these the two cases in front of each other, we find the similar findings of an ill-defined collection and overlying skin thickening, but on performing the T2, actually it differentiated both, because if it's intermediate bright in the T2, it goes more with the benign mastitis, but the low signal in the T2 weighted image was going more with the malignant mastitis. T2 weighted image is a very important sequence in such cases. To summarize, the being of bright T2 signal intensity in the MRI with the ill-defined collections and the mild skin thickening favored the benign mastitis, and on the other hand, the dark T2 signal intensity, absence of collection, and the extensive skin thickening favors the malignant mastitis. Okay, the following case is a 61-year-old lady with a right breast lump. Her mammogram showed this multiple lesions of intermediate density. Meanwhile, the contralateral side shows this area of architecture, diffuse area of architecture distortion. The ultrasound of the right breast masses showed hypoechoic, different variable sized hypoechoic lesions with irregular outline and high vascularity, while the left breast shows area of architecture distortion, which also showed high vascularity on the color Doppler. Her MRI in the right breast confirmed the presence of the multiple masses, shows homogeneous enhancement, while the left side shows a regional or area of non-mass enhancement with areas mounting to be focal masses. Here we're confronted with different imaging features in the same patient. This may suggest different pathological diagnoses, where the patient in the right side, the right breast, after tissue biopsy was confirmed to be an invasive ductal carcinoma, which is most common to be presented by masses, while the left side, after biopsy, is confirmed to be a lobular carcinoma, which here more common to be presented by asymmetrical architecture distortion rather than masses. So here we have in the same patient two different pathological diagnoses. This is another lady coming with the right breast lump. Here, the area of clinical concern was apparent here with the large intermediate dense lesion and another lesion seen posteriorly. And also we found a focal area or a focus of architecture distortion. On the ultrasound, the lesion of concern was actually a complicated cystic lesion with turbid contents within. There is another lesion beside hypoechoic with macro or microlobulated outline. There also was another lesion, isoechoic, different in the morphology. Actually, all three lesions were at the same quadrant, about from 10 to 12 o'clock. They were not so far. So eventually reported this as a multicentric process with the different imaging features, but all are suspicious. But actually the pathology goes that the one of them, that the echogenic lesion proved to be an invasive ductal carcinoma, while this more hypoechoic lesion was a sclerosed fibroadenoma. So in spite of the both are one at 10 o'clock and one at 12 o'clock, but they are two different pathological diagnoses and two different imaging features. This also is another lady coming with a right breast bulging lump, performed her mammogram outside, and we found this large lesion of mixed fluid with fluid level. Actually, it is a complex lesion with an with an intracystic solid lesion after aspiration of the cystic component. And there was another beside the lesion showing a area of architecture distortion, more than being a lesion, not vascular on color Doppler. And there on the contralateral side, there was another lesion. Actually, it's benign looking, well defined, hypoechoic, goes with the benign looking features. So here we have two different imaging features in one breast, and both actually were suspicious radiologically and reported as PIRADS 4. Yet pathological, we found that the right breast here complex lesion proved to be an intraductal papillary neoplasm, and the another lesion here proved to be fat necrosis and fibrosis, while in the other breast, it was the contralateral breast was a fibroadenoma. So here we are faced with these three different pathological diagnoses in the same patient. So here is a very important message I want to deliver through these cases, that I should see, what we see depends on what we look for. So I should look for each lesion. I should scan very carefully the breast. I should avoid the sense of satisfaction on finding one lesion, two lesions. No, I should even any number of lesions I find, I should complete my scan. I complete the 2 breasts, complete all the quadrants, because any number of lesions could be seen. Any types of pathological diagnoses also could be found. Okay, this is a 34-year-old lady with the right axillary tail lump. The ultrasound showed this lesion with multiple cystic spaces. Actually, the preliminary ultrasound showed this ill-defined lesions, which was reported as a suspicious lesions. We performed her mammogram, as she is she was young, so we didn't perform her at first. The mammogram showed this axillary tail actually lesion with mixed density. So we brought the patient again for a second look ultrasound. We found that the lesion was that actual size of the lesion, not the preliminary one, with this internal shadowing, which actually I think it was a calcific foci. And what we assumed to be a suspicious lesion, actually all this are inside this large lesion. We performed her an MRI, and to be honest, the MRI was done after the tissue biopsy, just for confirmation of the pathological diagnosis. In the MRI, the T2 showed like cystic spaces, bright T2 with bright stare of fluid signal intensity. Clinically, the patient stated that she had a skin discoloration over this area, and also there was like skin volts also around, or skin tags along this area. So the biopsy and the tissue biopsy told us that it is showing dilated vascular lymphatic spaces, and actually it was a lymphangioma. And this was actually an interesting pathology, an interesting case. This is another case, came with post-right lumpectomy. Her mammogram actually showed the post-operative changes, nothing suspicious. Skin thickening and the calcific foci seen by the mammogram. Again, reviewing of the mammogram showed this coarse calcific foci and this more or less tubular densities. The ultrasound here just to confirm that this is a tubular structure passing under the skin with overlying skin thickness. We performed her also an MRI. Actually, we found this dilated vascular structures on dilated vessels reaching to the subclavian. And it was actually an AVM, or a vascular malformation. And also this is one of not the uncommon cases we can see in the breast. In the Radiographics 2011, there was an interesting actually paper of the vascular abnormalities of the breast who wants to review it. And it included a wide spectrum of the arterial and venous disorders. It classified the disorders and arterial, venous, and mixes, benign and malignant, with the more common we see in the hemangioma, lymphangioma, and the angiosarcoma. I hope that I could presented most of breast pathologies we can confront in our practice, and I hope I could went to the target. Thank you very much for your attendance, and thank you very much for giving me this opportunity. Thank you.